Thank you very much to the organizers of this conference for inviting me. My name is Jan Claassen. I'm an associate professor of neurology at Columbia University, and I'll be talking to you today about altered consciousness. These are my disclosures, my funding agencies, specifically the NINDS, National Institute of Health, and I'm a minority shareholder at ICE Neurosystems, but these conflicts of interest don't directly apply to this talk. I'll start out by talking about what is consciousness. Consciousness is the awareness of self and the environment, and what is required is a subjectively experience of, and self-report of mental representations. That is how consciousness has been defined since the time of the publication of this book by Fred Plum and Jerome Posner, before I was born in the 1960s, called Diagnosis of Stupor and Coma. If we think about impairment of consciousness, this is quite frequent. We all lose consciousness on a daily basis when we go to sleep. General anesthesia is quite common around the world, and these are induced states of disorders of consciousness or impairment of consciousness. But not infrequently, patients lose consciousness due to acute brain injury. Why is this a condition that's important to talk about in the critical care context? In the before the invention of ventilators, patients with disorders of consciousness very rarely survived the injury. Since the development of ventilators, initially you can see here on the right, early versions of ventilators, and then ventilators that got developed during the polio pandemic, an increasing number of patients started to survive with disorders of consciousness. This has been introduced in the subsequent years to general critical care and has revolutionized the care of patients with disorders of consciousness. Why is it important to talk about this? The impact of disorders of consciousness is tremendous. They're important for goals of care discussions with families. Families value the impact of disorders of consciousness greatly. Long-term recovery is increasingly seen. And there's a high emotional and financial impact, both of survival and also death with coma or disorders of consciousness, both for families and also for the society. However, there's a huge knowledge gap regarding the prevalence, the phenotyping of disorders of consciousness, and the prognostication. If we think about neuroanatomical model that underlie this presence of consciousness, there's one part that centers around the brainstem, the ascending arousal system that projects mostly through thalamus, but also outside of the thalamus to the cortex. There's an important circuitry identified by Nico Schiff's group initially, the mesocircuit that connects the basal ganglia circuitry with the brainstem and the cortical areas, important for preservance of consciousness. And then there's the cortex, where all of this information gets reassembled. And this is conceptualized and mathematically conceptualized by the global workspace theory developed by Dehaene in Paris. What causes unconsciousness? There's many reasons that can cause, many etiologies that can cause unconsciousness. We think about supratentorial structural lesions, for example, a big stroke or a tumor in the temporal lobe that presses on the midbrain. Infratentorial structural lesions, for example, a cerebellar hemorrhage that presses on the brainstem. Metabolic and non-structural pathology like infections or cardiac arrest. And rarely there's also psychogenic coma. The differential is extremely broad. And with this broad diversity of causes, there's even the diversity of causes for impairment of consciousness within a single etiology. Here are some examples from traumatic brain injury. You can see that all these patients were unconscious, and all of them had traumatic brain injury, but you can see that when a patient has an epidural hematoma, some have contusions with hemorrhages, diffuse axonal injury, diffuse swelling, subarachnoid hemorrhage, and subdural hematoma. So it's extremely diverse what can cause disorders of consciousness. How do I approach an unconscious patient in the ED? Important is that we approach every patient in the same way. Initially, of course, we start with ACLS, airway, breathing, and circulation. We identify the most likely category of pathology using the history and the neurological examination, and then start to already in the back of our mind categorize along this this paradigm of supra-infratentorial structural lesions, metabolic non-structural lesions, and psychogenic causes. This is important because it affects the treatment and how we treat these patients. Targeted therapies are then potentially given. We may lower the blood pressure depending on what the cause is. We may call a neurosurgeon to evacuate a hemorrhage. And then the initial management is standardized, and some guidance can be given by this ENLS, the Emergency Neurological Life Support Paradigms for Disorders of Consciousness. What is the trajectory of unconscious patients in the ICU? So this is where I see most of the patients then. Disorders of consciousness, they are very frequent. So some patients arrive already with disorders of consciousness. Some have delirium. Some have recovery from the initial consult, but then secondary complications. There are medical complications that develop, like a PE, for example, that causes hypoxia and the patient becomes unconscious. Medications may be confounding the assessment. Metabolic confounders like renal failure and hepatic failure have to be taken into account. But families demand guidance from us. And in many, many cases, at this point in time, it's a self-fulfilling prophecy. If we tell them early on that the patient will not recover, they will go along and the patients will not recover. Here you can see the post-injury days in a group of subarachnoid intracerebral hemorrhage and cardiac arrest patients. All of them initially came unconscious, and here some of them recover consciousness, some of them die, but even weeks after the injury, significant portion of them remained unconscious. How do we assess unconsciousness? Initially with the behavioral assessment. So this is the most important part. There's not really great comprehensive ways to assess consciousness. The most widely used one is the Glasgow Coma Score, which was developed for TBI patients. It is crude. It does give you an idea what the prognosis is in a TBI patient. It was sort of applied to many other etiologies, but it doesn't comprehensively assess consciousness. The 4 score is an sort of modification of that, takes also into account breathing patterns, but also doesn't comprehensively assess consciousness. The 60-second test for attention just focuses on attention, and this is only in high-level functioning patients. The gold standard in the field for assessing consciousness is the Coma Recovery Scale Revised. This was developed by Joe Giacino, and you can see here it goes through different parts of assessing disorders of consciousness, different features, and it's quite comprehensive. It's very quick to do this in a completely comatose patient or in a completely awake patient, but those patients that are in between, it may take a while. And so it's difficult to use that outside of the research setting. There are developments underway to develop an ICU version of this. So if we conceptualize disorders of consciousness onto axes, the motor function, where patients express that they're conscious, and the cognitive function, which is required to be conscious, you can see that comatose patients have very low motor function and very poor cognitive function. Fully recovered or locked-in patients have very relatively high, reasonably high motor function and very good cognitive function. But then there are states in between, vegetative states patients where they open their eyes but they don't interact with the examiner, minimally conscious patients where they may show some interaction with the environment, may even in MCS plus show some inconsistent command following, but these are emergent states in between recovery and coma. So what does the recovery potential depend on? It depends on patient factors like age, comorbidities, the environment, injury mechanism and location and the extent of injury, time to treatment, time from injury, and the best neurological exam. They're terrible at this point at prognosticating, and mostly the outcomes are self-fulfilling prophecies. So how can we tap into better assessments of the neurological exam? You can think about many different ways. You can look at resting measures like the EEG or structural imaging. You can look at perturbation tasks, so you give a stimulus to the brain. This can be by magnetic stimulation or electrical, or you expose the patient to a task, like asking them to imagine something. And then you record either functional MRI or functional EEG, and you can use that to prognosticate whether the patient recovers. So I talked briefly here about functional MRI. First case of this was published by Adrian Owen in 2006, where he put a patient into an MRI scanner and did a functional MRI paradigm, asked the patient to imagine playing tennis, asked the patient to imagine walking through her apartment, and he got similar activation patterns looking at the bold signal as in healthy volunteers. So this started a whole interest in this field. Are there patients where their cognitive ability is better than their motor expression of it? More recently, this data was published where a larger group of over 100 patients with mixed causes of unconsciousness were studied. They similarly were exposed to commands, so asked to keep opening and closing their right or the left hand, stop opening and closing the right or left hand. This was done over and over again. None of these patients showed motor expression of command following, but the EEG was recorded, was analyzed with machine learning algorithms, and it was found that 15% of these unconscious appearing patients actually systematically responded to the move versus the stop move command differently. And so these patients were in this state called cognitive motor dissociation, so the cognition was better than the motor expression. What was interesting is that those patients that had this activation had a much higher chance to recover. 44% had a good functional outcome a year later than those that did not. So those patients are in cognitive motor dissociation. They can be behaviorally appearing like coma, vegetative state, or MCS minus. They're in a CMD and they have a trajectory to recovery. This can likely, in terms of treatment, likely one size does not fit all. There's been medications like amantadine, sulpidem that have been tried, thalamic, electrical stimulation, directly or indirectly, and focused ultrasound. And likely we will have to understand the pathomechanism for each disorder of consciousness to then identify the best treatment for these patients. There's ethical considerations of the current practice. Most of what we're doing is self-fulfilling prophecy, but is increasingly science has made this less tenable, and we have to work on trying to deliver better care to these patients. So in the future, we hope that interventional trials can be developed to individualize treatment approaches, mechanisms of altered consciousness can be identified better, especially CMD, cognitive motor dissociation, assessments and interventions for resource-limited settings can be developed, and the Curing Coma initiative, which is an international initiative going on at the moment, bringing together experts throughout the world, hopefully will help along this way. Thank you very much for your attention.